Hello, and welcome to Women's Health. Women's Health is a program hosted by the Mayor's Commission on Women. My name is Kathie Urhmacher. I currently serve as the chair of the Mayor's Commission on Women. And today our topic will be thyroid disease. My guest today is Dr. Shannon Wakeley. Welcome.
Thank you.
And she's here to talk to us about the thyroid and some of the diseases of the thyroid. Let's start out first of all talking about what is the thyroid?
Well, a thyroid is a butterfly-shaped gland that sits right in front of your neck. When I talk with patients, I describe it as a bow tie. So that's right where it is. It has a right half and a left half. Each of them are called lobes, and they're connected by an isthmus. The thyroid's job is to make thyroid hormone, which is useful for many ways, which I think we'll probably get into, but that's exactly what it is and where it's located.
And where it's located. So what basically is the function of the thyroid? I mean, obviously it's making this chemical, right?
Mm-hmm, mm-hmm.
But what does that chemical do for us?
Well, that's interesting. Actually, if you look back in history, they never knew what the thyroid was. It was easy when they were going through anatomy. You could figure out the heart pumps blood. The lungs help you breathe, but they said, what is that thing that we found in the neck? And when they initially found it, they thought it was just there to protect the windpipe. It was like a shield, and actually that's how thyroid got its name, because thyroid means shield.
Is that right?
Mm-hmm.
Interesting.
But it wasn't until later on that they discovered that actually it makes thyroid hormone, which is essential to every cell within the human body. It helps with protein synthesis, with growth and development, and with cellular metabolism.
Okay.
It's something we can't live without.
Wow. So it's way more important than we originally realized.
It is. And most patients don't really know. Actually, when I see them, they say, I didn't know I had a thyroid, or where is the thyroid? And I tell them that's the point. The thyroid gland is there to help keep everything in somewhat of a steady state, normal level. It's not until something goes wrong that you actually notice it.
And I noticed that in some of the research it talks about your metabolism. Is that right? Is the thyroid involved in metabolism?
It is. It
Okay.
is. If you're not having enough thyroid hormone production, one of the common symptoms is weight gain.
And so that would have something to do with that.
Yes, definitely.
Yeah. Well, let's talk a little bit about thyroid disease. What are some of the most common types of thyroid disease?
The most common types that I see are hypothyroidism, which is an underactive thyroid gland in which the thyroid gland is not producing enough thyroid hormone. It's fairly common. Actually, in about 5% of patients, or 1 in 20 patients, can have this. It's more common in women than in men. The next problem that I see often is hyperthyroidism, which is the opposite. It's an overactive thyroid gland in which the thyroid is making too much thyroid hormone. It's not as common as hypothyroidism, only about 1 to 2% of the population, but again is more common in women than in men. And then the next thing that I see is thyroid nodules, which are quite common. Thyroid nodules can be actually felt on about 5% of patients. But if we start imaging everyone, say someone's walking down the street and we start taking a look, do an ultrasound, you can find them in up to about half of patients, actually.
Is that right? Really? That's interesting.
Yeah, I commonly get referrals because they found it on accident. Say a patient had a car accident, went to the emergency department, had a CT scan done, and there's a thyroid nodule. So.
And those aren't quite as dangerous, or?
Well, that's why I get to see them. Which ones do we worry about? If half of us have them, we're not going to worry about every single one of them. We do a thyroid ultrasound. That's the best way to look at thyroid nodules, and there are characteristics within the nodules that make us more or less worried about them. One kind of rough rule of thumb is if it's a centimeter in size or larger, I do recommend biopsying it to rule out the possibility of thyroid cancer. But that being said, thyroid cancer is not common. It's only present in about 5 to 10% of those nodules.
Oh, is that right?
So first thing when I see a patient, I say 95% of the time, this is nothing, we have to worry about it.
Okay.
But we found it, so now we have to take a look.
So now we need to know, and that's smart, right? So, okay, so again, let's review. Hypo means underactive, hyper means overactive.
Exactly.
Okay, so let's start with hypo, which you said is generally more common. Okay, let's talk about what are the symptoms? If somebody is having trouble and they don't even realize that it's their thyroid, what would be some of the symptoms?
The most common presenting symptoms are fatigue, weight gain, feeling cold all the time. Everyone else in the room is comfortable, but you're trying to find a blanket and trying to get warmer. It can be constipation, dry hair, dry skin. When you're not making enough thyroid hormone, it's as though everything slows down. Just everything is just not as active as it should be. But that being said, those symptoms are pretty vague.
I was going to say, I think a lot of people have some of those.
Everyone's going to have those symptoms from time to time, so they need to be persistent. And every patient's a little bit different. I have patients who get sent to me and they have their blood drawn and they have hypothyroidism, but they go, oh, I just thought I was tired because I have 2 little kids or something.
Right,
so,
exactly. So everybody that has chronic, or what they feel is like chronic fatigue would not necessarily have a hypothyroidism.
No, not necessarily.
Okay, great. And so what would be a common treatment then? Or let's first of all go back and say, how do you find out you have a thyroid problem?
A blood test.
A blood test, okay.
You can do a blood draw. They test thyroid stimulating hormone, or TSH is a common one, and you can also check your free T4 levels. So when I explain this to patients, the thyroid gland makes the thyroid hormone, and it can be measured as T3 or T4. Your pituitary gland, which is the master gland of the body, it sits up in the center of your brain. I tell patients about the size of your pinky finger, sits up right in between your eyes, kind of in the center of the brain. It makes thyroid stimulating hormone and tells the thyroid gland what to do.
Oh, I see.
If your thyroid gland is not making enough thyroid hormone, your brain recognizes that and it starts making more of that stimulatory signal. So your TSH levels get higher and higher and higher when you have an underactive thyroid.
Okay. So a doctor, when you go, like let's say for your family physician, and you go for a yearly check or something like that, is it common then to test the thyroid?
Yeah, it can be. I have a lot of patients who just on a yearly exam when they go in have their TSH drawn as a screening test.
And would that be wise?
I think it's reasonable. I guess this kind of gets into who do you test for it? Who do you screen everyone? And there's some controversy. The United States Preventive Task Force, which is one of the governing bodies that sets out recommendations such as how often you get mammograms, when do you start getting prostate checks or colonoscopies.
Sure, sure.
Their stance on checking for hypothyroidism is actually no stance. They said we're neither for nor against it. If you look at the American Thyroid Association, who is the main researchers in thyroid disease, they do recommend screening for thyroid disease in all women age 35, and if everything's normal, every 5 years afterwards.
Okay, so you wouldn't have to necessarily have it on a yearly basis if you're not having problems.
Right, right.
But if you are having problems, then obviously the blood test is the way to go.
Exactly. Mm-hmm.
Okay, so once you find out that you have some issue and they come to you, then what steps do you take then?
Well, for hypothyroidism, the treatment is thyroid hormone replacement. Well, the first thing I do is make sure that this is persistent. Sometimes we have a little, could be lab error. Sometimes you can have transient hypothyroidism and you actually get better on your own. But if it's persistent and you truly do have hypothyroidism, you go on thyroid hormone replacement, which is in the form of a pill. You take it every day and typically need for the rest of your life, which is something I have to really remind patients you have to take it every day.
Well, I guess that's true of a lot of things. We just have to add that to our routine,
yes,
right?
Yes,
that's exactly right. But so then with that particular medication, does that pretty much take care of it?
Yeah, you need to be on the right amount, and that's kind of the trickiest part of it is finding exactly how much do you need. And everybody's a little bit different, depends on what other medications they're on. It can be weight-based, so you have to tailor it to the individual.
Sure, sure, that makes sense. Okay, so that's the hypo. Now let's go to hyper.
Okay. So common symptoms for hyperthyroidism, or an overactive thyroid gland, you can think of as the opposite of hypo. So you have weight loss. You feel hot all the time when everyone else is comfortable. You can have a racing heart, shaky hands, diarrhea or loose stools. For women, your menstrual cycles can be off and irregular. So everything's revved up. They can have anxiety and just feel awful.
I guess if some people know the term metabolism, I guess. So if you feel like your metabolism is going overtime or something like that, that would be...
Right, but rarely people complain about that. I dropped 10 pounds without meaning to.
I'm not sure that a lot of people are going to complain about weight loss. Right, that's exactly right. So, but definitely it's important to have a baseline, and so perhaps making sure that you know whether or not you have any issues by blood tests, and maybe suggesting that to a physician if you don't already get it would be a good idea, or something like that, so that at least you can get started with a baseline and know what you're doing. Or
well, again, that would be controversial. If you're feeling fine, you really have no symptoms, so you don't necessarily have to have that
the
blood
test.
Yeah.
Well, and in these days and ages, we certainly don't want to make more tests if we don't
need
to.
Yes.
If we don't need to. But I know that you brought some websites, and we can show that, and that would be a way for people to reference to see what all the symptoms are, and they could look that up, and that could be helpful too. Okay, so now what about hyperthyroidism? What do we do for that?
Well, that's a little trickier than hypothyroidism. It depends on what the cause of the hyperthyroidism is. Sometimes the most common cause is something called Graves' disease, where you have antibodies that attack the thyroid gland and cause it to continuously make thyroid hormone. Sometimes people have something called thyroiditis, when you just release all the stored thyroid hormone. They typically get better on their own and don't require any treatment. There are occasions when if they have a thyroid nodule, the nodule itself can be producing too much thyroid hormone. So it depends on the cause.
Sure.
But the treatment could either be medication to slow down the thyroid gland, something called radioactive iodine, where you can actually kill the thyroid gland, or even surgery to remove it.
So if you killed the thyroid gland, then you would need to have the
Then you
medication.
need to be on thyroid hormone replacement. Exactly.
Right. Is it very common to remove the thyroid gland, or to kill it, or whatever?
Well, I guess that would be two different questions. As far as doing the radioactive iodine, that consists of you swallowing either a pill or liquid form of radioactive iodine. The thyroid gland, the thyroid is the only organ in the body, or contains cells in the body, that absorb iodine. So if you give yourself radioactive iodine, it will concentrate in the thyroid gland and it will kill that. That is a common treatment for Graves' disease, and otherwise it's not used.
Not really used very often.
For Graves' disease, it's used often.
Right. Now, how common is Graves' disease?
It is not that common. Again, 1 to 2% of the population. So much less common than hypothyroidism.
But is the thyroid the main, then, sort of victim of Graves' disease?
That's a good question. No, it's not the only one. It's the main one, but the antibodies can also attack the muscles that are attached to your eyes. And if you have seen anyone or start looking online for thyroid disease, Graves' eye disease, those muscles get inflamed and the eyes then protrude forward, something called proptosis. And it doesn't necessarily follow the course of the thyroid disease. You can treat the thyroid and you still might have some of the eye disease. It's a little trickier.
And that it does sound trickier. Okay, so we've got the nodules, we've talked about those. Now, do those sometimes need to have removal?
Yes, if we do a biopsy and it is suspicious for cancer, then I do recommend definitely getting either half or the entire thyroid gland removed, depending on if there's other nodules in there. There are times that we remove the thyroid gland if, say, the nodule was benign, but it's very large and it's causing symptoms. It's hard to swallow. Cosmetically, it's bothering them. And it just feels uncomfortable. It's difficult to breathe at times. That's an indication for getting the thyroid gland removed as well.
But there is thyroid cancer.
Yes.
Okay, let's talk about that just a little bit.
Okay. So thyroid cancer, again, I said is not, I always try and reassure patients, you've got a nodule. Everyone jumps right to it, thinking it's cancer. Only 5 to 10% of all nodules are cancerous. But that being said, thyroid cancer is actually on the rise. It's the #1 endocrine cancer. Again, more common in women than in men. Fortunately, it's very treatable. There's different variations of thyroid cancer, but the most common is a very treatable type of cancer.
And treatable how?
Taking the thyroid gland out, and depending on the size of the thyroid cancer and whether or not it has spread to any local lymph nodes, you can do radioactive iodine ablation to kill any remaining cells that are present.
So is it very common that it would metastasize in other places?
It's not as common as I guess it's a less aggressive cancer is what I should say compared to other ones. It's not uncommon for maybe to go to a lymph node within the neck, but usually with radiofrequency ablation you can kill any of those cells that have moved into the lymph nodes.
And what does ablation mean?
Good question. Ablation is basically a fancy term for when you swallow the radioactive iodine, it going into the thyroid gland or the thyroid cells and killing them.
Okay. Okay. So you're kind of doing internal radiation,
yes,
rather than external.
Exactly. Exactly. And it's always something I explain to patients. This is not classically what you think of when you hear chemotherapy in cancer. You're not going to be losing your hair and lose a ton of weight. It's very different.
Yeah, that's really true. Now, is there any specific group of population? You mentioned women. It's higher. And is there a reason for that? Do you know?
No, it's a very good question. We don't know. Thyroid disease in women in general, we don't know exactly why. There's been lots of research done, but there isn't actually a good answer. No definitive answer? No, no.
Is there a specific age that we see more or less, or are people more at risk as they get older, or?
I guess that depends on which thyroid disease we're talking about. Thyroid nodules definitely are more common as we age. And the hypothyroidism really can hit at any age.
It's really? Even in children?
Yes, it can.
Is that right? Interesting. So really, you said something about 35 and over for women. Is that sort of standard, or?
It's not. That's what the American Thyroid Association does recommend. You're seeing more instances of thyroid disease at that age or higher, but it can occur in any age.
And in Graves' disease, you mentioned, and I think that a lot of people have heard of Graves' disease. I'm not sure they know what that is, so it's great that we're talking about it. In Graves' disease, is the diagnosis basically the same in the sense that you do a blood test for that, or?
You can do blood tests. You can test for the antibody that's present in Graves' disease. A lot of times it's diagnosed by doing a radioactive iodine uptake scan, where it's similar of what I've talked about with the ablations in that you do swallow radioactive iodine, but it's a very, very, very small amount, just enough that the iodine gets within the thyroid gland, and you can take pictures of it and see exactly how much is being taken up by the thyroid gland. That helps us diagnose the difference between Graves' disease versus something called thyroiditis, or if it's one nodule within there making too much thyroid hormone.
Sure, sure, that makes sense. So often when we're talking about health, and certainly on this program, we talk a lot about preventative health. Is there something that we can all be doing to prevent that from happening?
No.
Oh dear,
no,
that's not great news.
Well, the most common cause of hypothyroidism in the United States is something called Hashimoto's thyroiditis, which is a very fancy, scary name.
That is
kind
of long.
It's the presence of an antibody that attacks the thyroid gland and prevents it from making enough thyroid hormone. We don't know what causes the antibodies. And actually, antibodies can be present in about 20% of the population, but not cause any thyroid disease. So it's tricky. I always tell patients, you didn't do anything to get the antibodies, and unfortunately, there's nothing I can do to treat the antibodies and make them go away. So no, I'm sorry.
So we can treat the consequences, but and the result, but we can't really do anything to prevent what's happening.
Now, this would be different if we weren't living in the United States. Outside the United States, the most common cause for hypothyroidism is iodine deficiency. And of course, supplementing your foods with iodine or iodized salt is something that can be done, and they are doing. But in the United States, we don't see that. We've got iodine in everything. So.
Is that right?
Yeah, it's very common.
In iodine, I know iodized salt, but what else do we have that has iodine in it?
And it's in the conditioners and flours, so it's in your breads, it's in your cereals, it's in lots of processed foods.
Is that right? That's so interesting. I did not realize that. Well, I do know, and I have heard that in underdeveloped countries that there is a lack of iodine, obviously, and that there was, I don't remember how many years ago, it was kind of a movement to try to get some of the countries to do iodized salt, and that's a process, I'm assuming, that it's pretty common here, but not necessarily everywhere.
Right.
So in different parts of the world, then thyroidism would be a bigger issue.
Yeah, yeah.
Interesting, interesting. So we're really fortunate to be in a system where we know what we can do and follow through with whatever treatments we need.
Right, right.
That's great. Speaking of that, and we're always obviously on our program interested in the healthcare system, people often ask about the price, about the cost. Is this expensive? Is it covered by insurance? Is this going to be a real concern financially? Would it be a hardship?
Right. You know, I haven't run up against too many issues with insurance not covering the test for diagnosing hypo or hyperthyroidism, or even the treatment. The main thing I run into is with treatment for hypothyroidism. A lot of patients' prescription plans prefer to pay for the generic medication versus the brand name.
And is that an issue?
It can be. I think it's definitely okay for patients to be on generic medication, and I always just counsel them that the difference between a generic medication and the brand name medication is that when you get a different manufacturer that's making the generic, there can be a 10% difference from one manufacturer to the next, and that can really throw off a patient's labs and make symptomatically not feel very well.
Well, that can be really true. Is that generally true with all generics? There's a 10% difference?
It can be. That's the FDA says it. As long as it's 10%, it's okay.
Is that right? Oh gosh, I'm not sure that's very reassuring.
Most times it's fine, but with thyroid, it can throw people off.
It can throw people off. So is it possible for you to suggest that they use the brand name drug?
You know, if they can, but if it's going to break the bank, I don't want to put any stress on a patient. If they can afford the brand name, and some people's copays, it's no difference, then I say, yeah, do the brand name. But if they can't, we do generic, and I just have them make sure they look at the shape of the pill, the color of the pill, and if it's changed from one month to the next, they might have gotten a different manufacturer and just need to pay attention to their symptoms. Maybe we should make an adjustment. Or they can even talk to their pharmacist and find out, do you change manufacturers often, or can I make sure that mine is the same all the time?
So generally you're feeling that insurance is covering it?
Yes. Yeah.
Okay, and let's say, for example, we have someone who doesn't have insurance, which sadly there are quite a few people that don't, then what would be their options?
Well, a lot of, actually, generic medications are pretty affordable for the generic thyroid hormone replacement.
Well, that's good news.
Yeah, so it's not bad. You know, we try and get samples as much as we can as well.
Right, exactly. Well, let's say that nobody finds out that they have a high thyroid problem. So what would be, let's say if you're not diagnosed, if you never maybe either seek medical treatment for some of the things you're talking about, because, you know, a lot of us would make excuses, well, I'm tired, well, I'm gaining weight, and, you know, I'm doing all these things. So what would be sort of the long-term consequences if you don't get treatment?
Well, worst case scenario would be death, but fortunately that does not happen.
Okay,
very often.
Good to know.
Because people seek out care, and we've got good treatments, and it's easily diagnosed. When you don't have enough thyroid hormone, the worst case scenario is something called myxedema coma. You've got confusion, you may be obtunded, unresponsive, your body temperature drops, your heart rate drops, blood sugars can drop, sodium levels can drop, and you need, obviously, you need immediate attention and are hospitalized. But with thyroid hormone replacement, you're better. It's treatable.
So if you did let it go too long, and then it was obviously critical, and you go in and you're going into the hospital, it's easy enough to recover from that?
Well,
then?
I mean, it's if you let it go. I mean, I'm not saying that you could never die from it. It definitely has high risks, but once you're there getting treatments, most people do okay if it's caught.
Pretty curable.
What I typically see is not those extreme cases, but oh yeah, I forgot to take it here, or forgot to take my medication there, and the blood work is not really where we need to be. They're not as well controlled. Not having your thyroid hormone adequately replaced is going to lead to more weight gain, just more fatigue, higher cholesterol levels, in fact. So I always just really try and emphasize, you got to take this.
Yeah, right. Now, you said it's more common in women, but men do have it, obviously.
Yep.
Is there any specific age group, or is there anything specific about that you notice?
You know, in my practice, I see it at all ages. It's more as patients age, but I see plenty of patients. I mean, I don't do pediatric endocrinology, I see adults, but I see men in their 20s with thyroid disease as well as men in their 90s. So,
boy, that's interesting, isn't it? But then, like you said, if it's an antibody, then obviously you have that in your life, right? No matter what. Now, I noticed you brought us a couple of things here. Could we just look at that real quickly with a few minutes that we have left?
This is just the model of a thyroid gland that I show patients.
I think this is interesting because a lot of people don't know what it looks like.
So this would be your windpipe or the trachea, and the thyroid gland just sits right in front of it.
I see the butterfly idea.
Yes, yep.
There you go.
And these are just other examples of what maybe a nodule would look like, or at least to explain to a patient. And in a large thyroid gland, such as what you would see with Graves' disease when you have an overactive gland. When you've got, you can also have a goiter or an enlarged thyroid gland if you have hypothyroidism or Hashimoto's. So sometimes it's hard to, they can both be enlarged.
Those are examples. Well, thank you so much.
You're
welcome.
I
think that this is a very important thing to talk about, and I also think that it's probably not something that a lot of people know a great deal about. So we really appreciate your being here and letting us know this is a very important topic. And thank you for joining us today. This has been a segment on women's health. Today we were talking about thyroid disease. And if you would like to get more information, we've provided some websites for you. Again, thank you for joining us today on Women's Health.